It is a pleasure to introduce Dr. Reid Pyeritz. Dr. Pyeritz leads a little introduction to this crowd. He's not but a pioneer in the world of inherited aortic disease. So today, Dr. Pyeritz is going to talk about medical therapies of thoracic aortic diseases.
Thank you, and particular thanks to the organizing committee and all of the sponsors for this great second annual meeting. A couple of comments before I start. First of all, in preparing this, I had no idea that the words real world were in the topic assigned to me, so I will have to leave it up to you to determine whether, in fact, I achieved that goal. And second, my talk couldn't be nearly as interesting or challenging as Gregor's talk has just been, particularly as someone who has a bicuspid aortic valve. So I appreciate your comments, Gregor. So I always think that we ought to look at our current perspectives in light of what has preceded us. So here's a copy of Newsweek from many decades ago, and I was asked to comment on it, and I now know that there probably are genetic predispositions to being hit by a car. So basically everything that occurs to us is, in one sense or another, genetic. And no less than Francis Collins, some years later, verified that by saying we're all at risk for something. And as we all know now, genetic analysis is really the precision of precision medicine, which all of us, whether we know it or not, should be practicing for all of our patients these days. So these are the topics I'd like to address. I think we've learned something about medical therapy from the Marfan syndrome, but all familiar aortic disease, as we well know, is not Marfan syndrome. So how do we need to adjust medical therapy based on the diagnosis? We need to talk about current distinctions in treatments and conclude by looking at the concept of precision medicine. So what we've learned from Marfan syndrome really dates to the time when Victor McCusick was initially focusing on this condition and beginning in 1954. And being a cardiologist himself, the initial focus was on the aorta, as it became increasingly known that there was dilatation and dissection. Victor himself was quite accomplished in the world of internal medicine, cardiology, and became one of the founders of the whole field of medical genetics back in the 1960s. And without having to belabor this fact, we know that the principal aortic complications in Marfan syndrome involve the valve, usually by stretching the annulus, and aortic dissection, which leads to the list of complications seen here. And based on a study of patients defined as having Marfan syndrome back in the early 1970s, you can see that life expectancy for both males and females was markedly reduced compared to the existing data on life expectancy for men and women in the United States. Now, we all know that what was diagnosed as Marfan syndrome in the early 70s wasn't all Marfan syndrome. So these data are contaminated with many of the other familial aortopathies that we've been discussing. But nonetheless, this has been touted for a long time as what the life expectancy is if there is no medical treatment or surgical treatment. Surgical treatment was started by Hugh Bentall with his composite graft, and the man with whom I developed a long-time relationship at Johns Hopkins, Vincent Gott, really was one of the pioneers of using composite grafts both in emergent situations and prophylactically in Marfan syndrome. And the early results showed that life expectancy was greatly improved if you were able to do composite graft surgery pre-symptomatically. The first pharmacological trial in Marfan syndrome was begun in the late 1980s. This was done at Johns Hopkins, and it was beta blockade versus nothing. The patients were randomized. They were not blinded. The investigators were not blinded. And we followed them by echocardiography for a decade. And you see that the patients who were not treated, which we called a control group, had a more rapid increase in aortic diameter over a decade compared to the Marfan patients who were treated. Now, again, I'm sure this population was contaminated somewhat by patients who we would not now diagnose as Marfan syndrome. So the good news is it was randomized. The dose was optimized based on what the heart rate increased to when the patient ran up and down 2 flights of stairs. I would advise using that today as a good criterion. If you want to keep the heart rate under 110, then you adjust the beta blockade dose appropriately. I also emphasize that back in those dark ages, the only beta blocker available was propranolol. But we did have a long follow-up, and as I've indicated, there were weaknesses to this study, but it's typically identified as being one of the first pharmacologic trials. I looked recently that since 2006, there have been 123 articles, at least by title, emphasize beta blockade and Marfan syndrome. Not all, in fact, depressingly few of these articles actually look at anything comparing beta blockade as therapy with anything else. So since the early 1980s, there has been clearly increased awareness, which has led to earlier diagnosis. Patients have regular follow-up. We typically suggest not exerting at maximal capacity or isometric. And I think beta blockade has been, for many years, a standard approach to medical therapy for folks with defined Marfan syndrome. And we do prophylactic surgery and counsel about pregnancy and so forth. And this has led to increased life expectancy. So for females and male, how do we go back here? Nope. Let's do this. Sorry about this. Must be the French language confusing me. So you, I hope, remember the previous slide. So here we know that there's even been better survival with 50% probability of survival now for males into the 50s and females into 70s, and this is based on a study out of England with 206 patients. So both medical and surgical therapy are having a very positive impact on survival. Here we go. Wait a minute. I can do it.
Okay, you're good.
And so with the definition of mutations in Marfan syndrome in 1991, we now know that there are many mutations, some causing Marfan syndrome and some not. So certainly simply finding a mutation in fibrillin does not indicate the diagnosis of Marfan syndrome. So we have to keep that in mind in constructing any future medical trials. And of course, we used to think, we being those of us who are of a certain age, that fibrillin was mainly a structural molecule, and mutations in it led to weakness, and that was the pathophysiology of Marfan syndrome. And I won't belabor the points already made much better than I could, that the pathophysiology involving fibrillin is much different. And this is a very early example of understanding of pathophysiology, only involving a couple of genes. And as Bart has emphasized, the development of new drugs is going to be very dependent, if not entirely dependent, on understanding the pathophysiology, not only of Marfan syndrome, but of all of the aortopathies that we are discussing. And in fact, that is the foundation of precision medicine in all of the conditions that interest us the most. So again, an example that Bart has emphasized and was key in helping to define is angiotensin receptor blockers. And mice clearly responded very well. This is an older trial, but the study Bart showed earlier emphasizes that angiotensin receptor blockers may be even better. And the early study in severely affected children of Marfan syndrome showed that if they were only on beta blockers, their aorta was increasing, and then on an ARB, the rate of enlargement slowed. And this led to the now famous clinical trial, which was begun a decade ago, in which 611 patients of young ages were randomized to losartan or atenolol. We would have loved to include a placebo group, but the parents were almost uniform in saying they didn't want to be part of a placebo group. So the subjects were followed for 3 years, and the main outcome measure was aortic root diameter. Oh, I hesitate to try to go back again. But in any event, there was little difference between those individuals treated with beta blockade compared to those treated with losartan. And the main conclusions were that they were equally affected. We would have benefited from a placebo group. But nonetheless, the fact that losartan was effective is an illustration of the power of translational research, and we'll see many more examples of that today. So after that pediatric heart network trial, there have been 5 other studies that I could find comparing ARBs with or without beta blockade. They are of varying structure, different endpoints, and there's no conclusive evidence that ARB treatment is superior. The doses of the drugs were not equivalent. Ages vary, size of aorta vary. They were underpowered by and large, generally no placebo, and few, if any, clinical outcome measures. So here I list the ideal trial. I don't expect you to be able to see these. There are many factors that one could define as something we should consider in defining the next trial, comparing ARBs and beta blockade and anything else in any of these conditions with which we're most interested. Imagine trying to include all of these definitions in any single trial, which obviously we couldn't do. And then what about secondary outcomes? And here's a list of them. So also think about what you want to evaluate in designing any trial of medications in any of these disorders. And so currently, a recommended approach is to base the original therapy on aortic diameter, but talking about environmental factors, here was a study published this month that showed that your aortic diameter is affected by how much time you spend sitting at your computer. And for those folks who got exercise, they did much better than those folks who sat on their butts all day. So while we clearly modulate exercise recommendations in Marfan syndrome and probably all of the aortopathies, we shouldn't tell people not to exercise, but do it in moderation. So there are continuing controversies. This picture was published 2 weeks ago of two galaxies colliding, and who knows what that will look like in 10 years, Bart. You can make a prediction if you'd like. But we're also hoping that there will be some rapprochement with the competing interests in designing medical therapy, although some of us may be skeptical as to whether that will occur anytime soon. So here is a brief list of the complications in current trials in hereditary disorders, and they much reflect what we have already defined, and it's complicated by the fact that average life expectancy in the United States is actually decreasing. It's not true in many developed countries around the world. One of the factors affecting that in the United States is, as I indicated, a lack of exercise. There are other factors influencing the decreasing life expectancy in the United States, but it's something that needs to be factored into, again, design and interpretation of physical studies. So the next few slides, Diana has already discussed, and I would just emphasize that not only do we have to take specific genes into account in designing trials and dividing patient groups appropriately, but as she has shown beautifully with her ACTA2 analyses, mutations in arginine 129 have a much worse prognosis than other ACTA2 mutations. So if you were doing a trial of any pharmacologic therapy in ACTA2, you certainly would want to do genotyping of your patient population before randomizing them into any pharmacologic trial. So we have a number of different pathways involved, and they should be accounted for in designing future trials. And so genetics, and obviously I'm biased being a medical geneticist, genetics, I believe, is the future of medicine. And this cover was from the early 1990s. And so I think all of us have had a role to play in increasing the importance of genetics in medicine going forward. And this will only increase such that if we're going to tread on the yellow brick road, the goal has to be looking at our genes and how they influence both our health and our disease. Thank you very much.